Yes, audible.
Hello.
Audible, sir.
Hello.
Yes, sir, audible.
So first, let me introduce myself. Myself, Dr. Pranay Hazare from Can Innovation. I am a junior clinical expert at Can Innovations. So we will please join me in welcoming our webinar speaker, Dr. Mayura Kudva. So Mayura Kudva is a founder and chief physiotherapist at a Physio for You Scoliosis Rehab Center in Bangalore, which is one of the most first center dedicated to conservative management of the spinal deformities. She is the India's first COD certified therapist, Germany, and accredited in CES therapist, Italy, which is the advanced training in an international recognized evidence-based scoliosis rehab, evidence-based management approaches, including Leon, Diomede, and side shift methods approved by SCOD. With 25 years of physiotherapy experience, more than decades focusing exclusively on the scoliosis and spinal deformities, Dr. Kudva is a strong advocate for the proactive scoliosis care, challenging the traditional wait and watch approach. Has lead school-based spine screening programs and early detection of the scoliosis and kyphosis, and also received an award-winning recognition for her research in adolescent scoliosis screening. Is a regular speaker and workshop faculty at a national forum. We are delighted to have her with us today to share the clinical insight and experience. Let's warmly welcome Dr. Mayura Kudva. Ma'am, please share your screen and enlighten us with your clinical knowledge.
Just a moment, there's some issue with the. Are you able to see the screen now?
No.
There's some, sorry about this. The moment. Okay, now? Yeah, just a moment. You're able to see the PPT now? Hello?
Yes, ma'am.
Is it, yeah. Yeah, hello. Good evening, everyone. And thank you all for being here. Thank you for the introduction, Dr. Pranay. I'm really happy to share with you all my curiosity, experience, and learning with the plantar pressure system that I have been using from CAN Innovations over the past 2 years. I work mainly on scoliosis and spine deformities. And you must be thinking why I must be working with feet. That's the interesting part. But before we begin with the webinar, again, I'm curious and I'd love for you to type in the chat where you're joining from. It would be great for us to know where you all are listening or watching from. I am Mayura Kudva from Bangalore. I hope the PPT is visible and you're able to hear me. As physiotherapists, posture assessment is something we do every single day. We observe, we palpate, we analyze alignment, curves, symmetries, weight shift, and very often we make confident clinical statements like more weight on the right, collapsed arch, pelvic shift, compensatory scoliosis. These are educated assumptions, but they are still assumptions. But today, I want us to pause and reflect on one question. Are we truly assessing posture or are we assuming posture? Because posture is not just what the body looks like, it is how the body manages load, balance, and compensation over time. And that is what today's session is about, moving the posture assessment from what we think, we see, to what the body is actually doing. Why the posture assessment needs upgrading? Is there a problem with the traditional posture assessment? Let me say this clearly. Traditional posture assessment is not wrong, but it is limited. It relies heavily on observation, and observation by nature is subjective. Two experienced physiotherapists can assess the same patient and reach two different conclusions. When two therapists see different things, the issue is not skill, it is subjectivity. Objective measurement helps us reduce bias, improve inconsistency, and support clinical reasoning, especially in cases of early scoliosis or cases of subtle postural imbalance or even chronic pain patients who look okay. Of course, we can use plumb line, pictures, scoliometer, inclinometer, etc. to measure the alignment too. But the biggest limitation is this. We observe alignment, but we don't measure load. And tissues don't respond to alignment. If posture is about load management, then measurement becomes essential. So, shouldn't we be measuring the load? Just a moment. Is there? Yeah, can you hear me now?
Yes, ma'am, you are audible.
All okay, right? The PPT. There was somebody scribbling on the screen. So these images demonstrate how even small spinal deviations influence weight bearing on the foot. In the first case, a left lumbar scoliosis with a compensatory thoracic curve shows greater weight bearing on the left foot as expected, as the trunk is shifted towards the lumbar curve, that is the major curve. In the second case, although the left thoracic curve appears larger than the smaller right lumbar curve, weight bearing is shifted to the right. When the central sacral line is drawn, the coronal imbalance is clearly toward the right, with the lumbar apex further from the midline than the thoracic apex. This was also evident clinically using plumb line assessment, even though orthopedic focus was mainly on the thoracic curve due to the higher curve angle and the rotation. While uncommon in moderate to severe curves, where the body weight usually is towards the major curve, this pattern can be seen in well-balanced double curves or mild curves in scoliosis, where weight-bearing analysis becomes a key deciding factor in early intervention. Achieving symmetrical weight bearing and coronal balance is one of the primary goals of for three-dimensional scoliosis therapy. And plantar pressure mapping helps confirm clinical reasoning and track progress over time. So, why do we start with the foot? Because the foot is our only contact with the ground. Every posture strategy, every spinal correction, every balance response must ultimately express itself through the feet. Yes, clinically, we often work in silos. Any issue with the foot, we think of orthotics. Spine, we think exercises. Balance, something else. The body doesn't work that way. Let me be very clear here. The foot does not cause scoliosis, but the foot reveals how the body lives with scoliosis. The plantar surface is not just mechanical, it is also sensory. It constantly feeds information to the nervous system about balance and load. So when posture changes, the foot adapts. And when the spine is altered, the foot compensates. That's why plantar pressure mapping is not a foot tool. It is a posture control assessment tool, I would say. This is where pressure mapping enters the conversation. Plantar pressure mapping allows us to objectively measure pressure distribution, hindfoot, barefoot loading, peak pressure zones, center of pressure, left right asymmetry or symmetry, static and dynamic loading patterns. It shows us things the eye simply cannot detect. And this becomes especially powerful when we compare what we see with what the data shows. Very often they don't match. One of the most important concepts I want you to take from today is this: static posture and dynamic posture are not the same entity. Static, standing, tells us the habitual loading, postural preference, or where the body likes to stand. Dynamic tasks, walking or balance challenges, tell us the postural control, the neuromuscular strategy, adaptability, or balance ability. I often say this: static posture shows where the body prefers to stand. Dynamic posture shows how the body survives movement. Both are essential and they often tell very different stories. Now let's ground this in evidence. A 2023 systematic review published in Gait and Posture by Fabian Tomchi and colleagues examined the relationship between foot pressure and spinal parameters in healthy adults in static and dynamic conditions. These studies didn't just look at the posture visually. They measured plantar pressure, load asymmetry, peak pressure, and also impact from changes in head position, trunk displacement, pelvic rotation, spinal movement. Even muscle thickness was measured using ultrasound. And what did they find? Yes, there is a relationship between foot pressure and spinal parameters, but it is partial. That is, foot pressure does not reflect the entire spinal posture. Plantar pressure is one piece of the puzzle, not a full postural diagnosis. It is inconsistent. You will not always see the same plantar pressure pattern for the same looking posture. Also, it is context dependent. It reveals how the body is responding under specific conditions. Especially interesting, head position alone could alter plantar pressure in static standing. But dynamic walking showed no consistent correlation unless posture was deliberately manipulated. This tells us something critical. What we see in standing does not predict how the body behaves in movement. Another interesting fact is one of the most powerful findings was this. When lumbar muscle thickness increased, plantar pressure decreased. No foot intervention, no orthotics, no gait cue, just improved muscle control. Think about that. It means the spine can influence the foot just as much as the foot influences the spine. So, when plantar pressure changes after spinal rehabilitation, it doesn't mean the foot improved. It means the control system improved. This is something visual posture assessment simply cannot capture. So, why we miss these changes clinically? Here's the honest truth. Many of these changes are small, subtle, statistical. You won't see them on a posture photo, in a mirror, or in a quick standing observation. When we say posture looks okay, what we may actually be saying is our assessment tools are limited. That's not a failure of skill, it's a limitation of measurement. Now, let's bring this into scoliosis. Scoliosis is not just a spinal deformity, it's a balance problem. The body's priority is simple: keep the head upright and eyes level. To achieve this, compensation occurs either in upper spine, head, and neck at times, but often far away from the curve at the pelvis and the feet. In scoliosis, we commonly see asymmetric loading, overloading on convex side of the major curve, COP deviation, altered heel forefoot distribution, dynamic gait asymmetries. And here's a crucial point. In scoliosis, symmetry is not the major goal, the balance is. Plantar pressure mapping helps us understand how the body achieves that balance. In static standing, scoliosis patients often show unequal weight bearing, mid-foot collapse on one side, reduced symmetry index. These patterns affect the trunk shift, reflect the trunk shift, pelvic obliquity, or long-term compensation. But static standing only shows part of the story. Walking reveals much more. In gait, we often see unequal stance time, altered push-off, abnormal COP trajectory. This is why I say walking exposes scoliosis more than standing. Dynamic pressure shows how the body manages instability. Clinically, this becomes very practical. A simple protocol, static pressure assessment, dynamic walking or balance tasks, identify the asymmetries and COP behavior, apply postural correction or exercises, reassess either immediately or after a few months. In scoliosis and postural rehab, this allows us to check pre and post Schroth correction, to validate corrective strategies, to guide treatment direction, to provide objective patient feedback, and track the changes over time. Pressure mapping does not replace clinical reasoning, it sharpens it. Let us discuss about a case pre and post Schroth therapy for scoliosis. This is a 16-year-old boy with adolescent idiopathic scoliosis, a right thoracic scoliosis, clinically presenting with asymmetries, uneven shoulders, prominent hip, rib prominence, prominent shoulder, etc. Coronal imbalance of 2 centimeters from the midline towards the right clinically. So pre-Schroth, there was increased sway distance and sway velocity, unequal weight distribution, But post Schroth therapy, he had improved weight distribution with shift towards the left side, reduced sway distance and sway velocity, improved postural stability, and frontal plane symmetry. That means was well balanced in coronal plane. Here you can see pre and post Schroth in a bipedal stance report, how the weight bearing has reduced from 55 on the right to 47 now, thereby improving the weight bearing towards the left. Also in the stabilometry, you can see how the sway distance has improved and velocity is improved, and also how the weight distribution is more balanced bilaterally. As I told you earlier, one of the major aim after a Schroth exercise program is to see that there is a good shift, weight shift towards the opposite side of the major curve. Here you can see how in the ISST Schroth method, we divide each curve and make a body schema as in the first image and make a therapy diagram and then administer the exercise program. Tailoring the exercise program based on each curve. The diagrams and the exercise shown here are only indicative and symbolic. They do not represent the same curve pattern. You can see how intense this exercise is. Working on all three dimensions through alignment, muscle activation, and breathing. You can see how the body learns to shift. To learn this approach in detail, join the ISST Schroth method courses happening this year. Follow my social media pages for updates and more scoliosis specific insights. Feel free to reach out to me on this regard. Post Schroth, you can see how the curve that was deviating to the right is now more balanced. Pelvis and head are almost in alignment. Clinically, the coronal imbalance reduced from 2 centimeter deviation to less than 1. We also got the affirmative on the foot scan as we discussed earlier. So the key takeaways from today, that is posture is load management. Feet reflect postural strategy. Static and dynamic posture tell different stories. Muscle control matters more than alignment alone. What we don't measure, we underestimate. And most importantly, the feet do not create scoliosis. The feet do not create scoliosis, but they clearly reveal how the body lives with it. And most importantly, um, yeah, and I would also leave you with this thought that the absence of a visible imbalance does not mean the absence of biomechanical imbalance. If we truly want to upgrade posture assessment, we must upgrade the way we measure it. Thank you for your attention. I'd be happy to take your questions.
Hello, everyone. If you have any questions, please write it in the chat box, please. Hello, Dr. Mayura. We
Hello.
have
Yeah.
one question.
Mhm.
How exact we do pressure mapping?
How exactly we do pressure map?
Yes, ma'am. We have this question from Miss Sumedha Jain.
Yeah. Yeah, sorry. Yeah, Ms. Sumedha. So there is this plantar pressure system that is provided by Can Innovations. So we stand on it, and the sensors on the mat actually measures the way you are standing. It measures the weight bearing, the etc. on when you're standing as well as while you're walking, and the different measurements it gives.
Okay. We have another question from Miss Janvi. She is asking for the correction methods.
The scoliosis, the short method. Yeah, you can connect with me on this regard. Yeah, there are several scoliosis methods, like the Schroth method mainly that I practice, and the CS method, and Leon, dopamine, and side shift. There are several methods that are evidence based and come under by they are recognized by SOSOT, that they are evidence based. And Schroth method is especially a three-dimensional corrective method for scoliosis. Yeah.
So,
Have I
ma'am,
answered your question?
ma'am, we have another question as well.
Yeah.
From Dr. Akifa. Posture through fit, is there any evidence-based, ma'am?
Pardon me?
Posture through fit, is there any evidence-based, ma'am?
Posture through feet is it? Can you make posture through feet? Is there any? Yeah, there are several researchers that are already done, and there is a lot more scope for you to work on by. Yes, it is. There is evidence. I presented one already. About one research I did speak already. So there are a lot more other researchers, and that is the research that I spoke on is based on 700 other researchers. So, and they have found that there is an impact of the spine on posture, the posture on the feet and the feet on the spine. Yes.
Ma'am, we have next question from Dr. Arvind. Uh, Please tell me about the scoliosis advanced physiotherapy management.
Yeah, I think I just answered that question. That is, yeah, I work, I see, mainly with adolescent idiopathic scoliosis. We work with the physiotherapy scoliosis specific methods, and the most worked with is the Schroth method, the international Schroth three-dimensional scoliosis therapy that I work with. And it works on the scoliosis three-dimensionally, not like how we usually work, thinking that one side of the curve we open one side and the other side. It works in bringing back to the alignment, doing basic corrections and breathing and three-dimensional approach for scoliosis rather than the way we think it is one-dimensional. So Shroth is the method that I use, and says sometimes. Yes. These are all evidence-based methods that are what do you say, proved by SOSOT. SOSOT is a organization for conservative management of scoliosis worldwide, a worldwide organization.
Ma'am, we have the next question. Posture on feet and feet on posture is bidirectionally related.
Yes. Yeah, every little, that's what I said. Every little movement, once you stand on the plantar pressure mat and you do a small movement, you can see the change that happens on the foot. And also, you can see sometimes how the foot also impacts the posture. It is bidirectional, yes.
Okay. Doctor, there is one more question. How long does it take full recovery with the scroll exercises?
Oh, this is multifactorial. So it's not a very short term. Of course, maybe in a very, very mild case. But yeah, it's a scoliosis is a vast study for anyone. So and even during the growth age. So it's from the time when you're detected, diagnosed, till your growth is done. So or adolescent idiopathic scoliosis, especially, starts in the adolescence, or sometimes idiopathic scoliosis in the juvenile. So if it starts there, then till their growth is done, one has to take care of it, that it doesn't worsen. And until the growth phase is done, you have to see to it that you manage it and maintain it lesser than 30 degrees, so that we don't go into the zone of surgery. That is what early detection and intervention role we can play as physiotherapists, mainly. Yeah. So the treatment, I would say, even for mild to moderate cases, to get a good correction. So in the first year, we see a good coronal imbalance being corrected, and slowly also the rotation aspect being corrected. So it takes almost 1 or 2 years for you to see very good results on the X-ray as well. And the journey is long, however, the whole of growth phase of the child, you will have to take care of it and see that they don't progress more than 35 degrees. I hope I've answered your question.
So all questions are done, ma'am.
Okay. Yeah, thank you.
So here I would like to thank you, Dr. Mayura, for an insightful and highly informative session. Your depth of clinical experience and evidence-based approach for the scoliosis and posture management is a which give a valuable clarity to us, and your practical takeaways for us is a valuable insight for us. And I would like to thank all the participants for joining us today. We are looking forward to see you in upcoming webinars. We are continuing with exploring the innovations of physiotherapy and patient care. So thank you, Dr. Mayura. Thank you, all the participants. It's
Thank
great
you, Pranay.
meeting
Thank
with
you,
you.
everyone. Yeah.
Thank you, ma'am. Have a great day. Thank you.
You too. Bye.